much better. So we have to look at ways, how can we get to low LDL and avoid medicine? I'm all in favor of that. So if you can get to your LDL, your bad cholesterol, down to 50, and come back and show me this, I'm going to say, out of my office, you don't need my help. This is wonderful. The problem is only about 2% of us, myself included, who, by the way, I am on a statin medicine and I have no heart disease, but the majority of us cannot get that LDL down to these very low numbers we're talking about. So normal may not necessarily be what our goal is, and the goals have changed dramatically, and they're going to continue to change, because as the studies come out, we're finding that, oh my, 200 is no longer good, 180 is, and then it's going to be 170, and in the future it may be 150. The problem with that, the cholesterol levels in the US in adolescents are climbing, because they're raised on computer games, McDonald's, and no exercise, and you're going to see lipid levels continue to climb. So good news, your cholesterol has stayed the same, but research findings have changed. Again, what may have been normal 20 years ago, we're going to tell you that is no longer adequate. So what is cholesterol? Is cholesterol all bad? Of course not. We have to have cholesterol. Cholesterol is in your brain. It makes the lining of your neurons in the brain work. Cholesterol is in every cell of your body. So obviously cholesterol is good. Obviously, you need it. However, I keep talking about bad cholesterol. So what does cholesterol do? Let's look at a little video. These are LDL particles circulating through the cells. This is the endothelium of the cell. And when you have too much LDL, guess what? It penetrates the subendothelial area and turns into phagocytes. These are nasty cells. So here's endothelium normal, these smaller ones damaged. When you have too much LDL, again, too much, it penetrates and gets into the subendothelial space. Guess what it does? It damages the endothelium, causes those monocyte adhesion molecules, which then cause monocytes to adhere. The monocytes then penetrate the subendothelium and they turn into phagocytes, cells which eat the cholesterol. These cells which then eat the cholesterol become big, fatty cells. They're foam cells. These cells are very high in cholesterol, and they're very, very dangerous, because look what happens. So now you have these big, fatty foam cells, and what they do is release chemicals. And these chemicals cause these smooth muscle cells to move into the area, and the smooth muscle cells lay down plaque. And that's what's in the coronaries. When I do your heart cath, this is what I'm finding. I'm finding plaque in the arteries. And when that plaque, the plaque doesn't need to be 90% to cause a problem. Let's see what happens with minor plaque. So we know that repeated healing and injury leads to progressive occlusion of the artery. So all of us in this room, everybody here, including my beautiful 22-year-old daughter, already has plaque in her arteries. It's not going to be apparent angiographically, but I know it's in the artery walls. And what's happening, let's see what happens with damage. And so you're going to have progressive buildup. Now when you get to this level and the lumen is compromised, let's call that an 80% blockage. These are the patients I see in my office. These are the patients that say, Doc, I'm having tightness in my chest. I said, yeah, you're having tightness because you have an 80% blockage. So once the blockage is over 70% approximately, that's when people will have symptoms. And that's good. So if you have symptoms and I catch it before it causes a problem, great. Put a stent in, lower your cholesterol, stop smoking, control your diabetes and hypertension, you're good to go. The problem is most blockages don't get to this level before there's a problem. What happens is they're only about 30%, and then you get plaque rupture. These little things, those are platelets. They start sticking to the area of plaque rupture. More platelets come in. They form a white thrombus, white clot. The clot gets cross-linked with von Willebrand and fibrinogen. It sticks, red clot, boom, heart attack. So you just had a 30% blockage, undetectable. You couldn't tell you have it, you couldn't feel anything. And from whatever happened, stress, hormones, hypertension, diabetes effect, the plaque ruptured and boom, red thrombus, massive MI. Yesterday I had a 57-year-old, no warning signs, massive MI, couldn't save him. He died on the cath table. He got here in 90 minutes, Cardiogenic shock could not save him. The front artery completely occluded. This is real, and this is what we're trying to prevent. We're trying to prevent the pathophysiology leading to acute coronary syndrome, which is plaque rupture, leading to unstable symptoms, leading to ST elevation MI. And guess what? It's due to cholesterol deposits. So myocardial infarctions in the US remain high. We have the best technology in the world. We can put in valves through the legs. Annette is here, that's her program. We can seal the atrial appendage. We can put big heart assist devices. We can keep people alive until they get a heart transplant. I can take people who are near death and have them walk out of the hospital 2 days later. But we still have a problem. 525,000 new heart attacks a year. 190,000 recurrent heart attacks. These patients already have had another one. One heart attack every 44 seconds in the country. That's why I'm so busy. We don't have enough cardiologists to deal with this. And one person dies every 4 minutes from acute coronary syndrome. The disease prevalence is real. Let's look at this. I'm hoping this. Okay. Let's see if you can hear this. I want to show a little slide because, as I mentioned, cholesterol is not all bad.
If you or someone you know is diagnosed with high cholesterol is, and why it's important to keep it under control. Cholesterol is a fat-like substance made by your liver and also comes from foods you intake that is then packaged into particles called lipoproteins. Your body needs cholesterol to make hormones, vitamin D, and a substance that helps you digest food called bile. This video discusses two types of lipoproteins that carry cholesterol: low-density lipoprotein, or LDL cholesterol, also known as bad cholesterol, and high-density lipoprotein, or HDL cholesterol, also known as good cholesterol. LDL travels through your bloodstream, delivering cholesterol to the cells that need it. If your body has too much LDL, it can build up in the walls of your arteries. LDL and other substances in your artery wall form a fatty deposit called plaque. Over time, plaque can narrow the artery and reduce blood flow. LDL carries cholesterol into the plaque. This is why LDL is called the bad cholesterol. A common place this plaque can build up is in your coronary arteries, which are the blood vessels that feed your heart.
It's a heart attack here in the black.
This plaque buildup causes coronary artery disease and increases your risk of a heart attack. Plaque buildup in other arteries, such as the carotid arteries in your neck, can reduce blood flow to your brain and increase the risk of a stroke. Your liver also makes high-density lipoprotein.
Here's the good news, HDL.
Also known as the good cholesterol. HDL helps remove excess cholesterol from your cells, tissues, and from plaque in your blood vessels. This is why HDL is called the good cholesterol. HDL returns the excess cholesterol to your liver, which removes it from your body. If after viewing this information, you have questions about cholesterol.
Okay, so two types of cholesterol. The good cholesterol, HDL, heavenly cholesterol. The bad cholesterol, LDL. I always tell my patients lousy. Think of it as bad. And when we check a lipid profile, yeah, I want to know what your total cholesterol is, but I'm always going to ask, what is the LDL? And almost everybody sitting in this room, the majority of us, should have an LDL cholesterol of 70 or lower. Very difficult to get to, although it's possible with good healthy eating. And why do I say that? How low is too low of an LDL cholesterol? We don't know, because every study that keeps being done shows that the lower your LDL cholesterol is, down to 40 and lower, the lower your risk of death, stroke, and heart attack is. So lower is better. The same thing with HDL. Higher is better, the opposite. So your HDL, as it increases, your mortality decreases and your coronary heart disease risk decreases. There are populations they found that have LDLs of 140. Normal is about 40 to 50. Men 40, women a little higher, 55. And these people with these extremely high HDL cholesterols genetically don't seem to develop heart disease. So HDL is good cholesterol, LDL bad. HDL, we have no drugs on the market that are really intended to raise HDL. Nothing is tremendous as far as drug therapy. There's an old drug called niacin some of you may be on. Niacin raises HDL a bit, but the best thing for HDL other than genetics is exercise, and we'll talk about some new drugs which are hopefully 1 or 2 years away. So look, Doc, I'm a penguin. All I do is swim and eat fish. How on earth can I have high cholesterol? People tell me there's no way. You know, I have a normal body weight. I don't have any risk at all. Yes, you can have high cholesterol. Your liver is making 800 milligrams a day. Your diet's 300 to 400. So I have marathon runners who are vegetarian who have had heart attacks with high cholesterol. I have familial hyperlipidemia. I cannot get my cholesterol below 160 LDL without a medicine. And I eat healthy. Thank you, Jennifer. She cooks well. And, you know, maintain the weight and everything. Blood pressure cannot do it. So you can, on the outside, you can look fit and trim, but you still could have high LDL cholesterol. So we already touched on this briefly. Why does the body need high HDL? Why does the body need cholesterol? Important in vitamin D. It's important to make hormones, sex hormones, estrogen, testosterone. It creates cell membranes. Every cell membrane is held together with cholesterol. Coats the nerves in the brain, produces bile salts, which you need to digest food and digest fat-soluble vitamins, and it's somewhat anti-inflammatory. So it works to repair damage that happens due to stress, poor diet, and toxins. So cholesterol is a good thing. It's when you have too much. So what are the risks for atherosclerotic heart disease? The risk is significantly higher when you have multiple risk factors. I'm just talking about cholesterol. It's only one risk factor for disease. Many of us have multiple risk factors. Advancing age, can't change it. Over 75 in particular. Total serum cholesterol, low HDL cholesterol, high LDL, diabetes. If you're diabetic, you essentially can give yourself heart risk equivalent. So a diabetic, you can start with the premise, there's going to be heart disease. So diabetes is extremely important to control. Stage 3 and 4 chronic kidney disease. Those are moderate to severe kidney failure before you're on dialysis, extremely high risk. Cigarette smoking, extremely high risk. And then family history. Other risk factors which we have less control over include different types of apolipoproteins, apolipoprotein B and A, I don't want to get into that, some clotting factors, markers of inflammation, homocysteine, C-reactive protein. That's why your doctor may say, you know, you need a C-reactive protein level. And you look at him and say, what is a C-reactive protein? It's a marker of inflammation. So if you're 40 years old and you come to your doc and say, Doc, I'm worried, my mom had a heart attack when she was 50, how do I know? What do I know besides cholesterol and besides blood pressure? What can you tell me about my risk? High sensitive C-reactive protein, if it's significantly elevated, that's a marker of inflammation and puts you at other risks. And we'll talk about some other things you can use as markers for your probability of developing heart disease. But this is very interesting. So if you look at the attributable risk factors for a first heart attack, okay, we all know we can modify smoking, eat more fruits, vegetables, exercise more, alcohol in moderation, 2 5-ounce drinks for a male, 1 for a female would be moderate, blood pressure control. But of all the things you have most control over, it's lipids. So lipids tremendous control because we have such good medicines. You know, to go from a body mass index of 40 to 24, that is a struggle. You're talking 5 years of hard sweat equity and eating and really working on it. Lipids, you're talking a month of a medication when you can probably get in a normal profile. I'm not saying just medicine alone, it's lifestyle, it's eating healthy, but of all the attributable risk factors which we can modify, by far, lipids. So, we have something in the office when somebody comes in and says, Doc, what is my risk 10 years of developing heart-associated problems? So let's do a little test here. So I'm going to take out my calculator, and this is the ASCD risk estimator. Everybody should know their 10-year risk. Your doctor should be able to tell us. So let's do a patient who's 60. So I'm going to put this in the little computer. Let's take a male. Let's say he's Caucasian. What's a good systolic blood pressure? Maybe a little high. Let's give him a blood pressure of 140, so not too bad. Diastolic pressure 90, could do a little better. Cholesterol 240. I told you back in the 1970s 240 was normal. Let's say HDL is 30, could do a little better. Let's say LDL is 160, a little high. Diabetic, yes. Smoker, yes. Hypertension, yes on treatment. Not on a statin, no aspirin. So what is his risk? So this person has a 63% risk of developing symptomatic heart disease within 10 years. And I didn't put in really significant risk factors, a little bit smoking, hypertension, but you can actually use one of these risk calculators and look for your 10-year risk. And why is that important? Because we know prognosis. In the United States, by the time you're 80, most people, your risk for developing coronary disease is about 75%. That's the entire US population. And why does it matter? So if you look at these risk categories, low risk, no risk factors at all, very few of us are in that category. Moderate, 10-year risk less than 10%. I just said this person had a 10-year risk of 60%. He's way up here in the extremely high risk. And then the high extreme risk is you already have a problem. You've had unstable angina. It persists despite a low LDL cholesterol. You have poorly controlled diabetes, renal insufficiency. Those are the ones you really need to focus on aggressive therapy. Because look at what happens when you combine 3 risks and calcium in the coronaries. 34 times having 0 risk and no coronary calcium of developing an event. And these events are death, stroke, heart attack. So when you combine multiple risks to already established coronary disease, whether it's on CT calcium score or I've done a heart cath and found it, 34 times what you would be at this area. And again, we can change that. So the atherosclerotic coronary vascular risk estimator is the 10-year person's individual risk to establish a reference point. You can forecast the potential impact of interventions. So what happens if I take that LDL and drop it to 70? I can recalculate it, and you know what? The risk goes from nearly 70% down to about 20%. And you can assess follow-up visits, see how they're doing. So it's a neat tool. You can download it from the internet, put your own information in, and come up with the score. ASCVD Risk Estimator, free app online. And what they're looking at is your age, sex, race, blood pressure, cholesterol, diabetes, smoker, yes or no. Are you on therapy? Are you on a statin? Are you on aspirin? And that you can calculate your risk. You have to use one of the download calculators because we don't exactly know the numbers to plug in. So lifetime risk for atherosclerotic disease, lifetime in average population 46. As I mentioned, it's going sky high now in certain populations, particularly Hispanics and African Americans. A lot of that is lifestyle. Optimal 10-year risk is 3.4%. If you're plugging into this calculator and you're getting down below 5, you're doing pretty well. If you're under 5%, I don't recommend a statin. So here I am, a physician who's on a statin, telling you if you're very low risk, don't take a statin. Why do you want to take a medicine with potential side effects? Problem is most of us are here today for a reason, and that is either we or a loved one or a family member or a relative, somebody has disease and they're here for a very good reason, so all of our risks are probably much higher. And then the guidelines for blood pressure do not specify treatment, and we talked about this last time if your blood pressure is in the normal range. I'm going to skip through these. So, screening test. I mentioned before, what if you're that 40-year-old and you really don't know and you say, Doc, can you give me a little more evidence? Can you tell me what if I have 3 risk factors? Suddenly my chance of getting disease is much higher. Yes, you can do a coronary calcium score. So for $80, if you pay out of pocket because insurances often deny it, you can lay in a CT scanner. We can calculate your calcium score. If you have 0 calcium score, you're in pretty good shape. If your calcium score is over 100, you're predisposed for disease. You can get a high sensitivity C-reactive protein. I mentioned before that's a marker of inflammation. So if you're a 50-year-old with a strong family history but you have no disease and your doctor tells you your hsCRP is high, your coronary calcification is high, and your carotid intermedial plaque is high, you want to be aggressively treated. So that may be a reason for you to accept a statin medicine. So if you're healthy, but you have all these markers and your cholesterol is a little high, instead of ignoring it, you're going to be more aggressive. So I'm a big fan of these. Now some things people say, well, Doc, why don't you get a folate? Or why don't you get a homocysteine level? The routine measurement of homocysteine is not recommended because there's no treatment for it. There's no really thing to impact that. Folate really hasn't helped. So you'll see online sometimes, check this, do this, do this, do this, but there's no evidence base for it, or it can be actually harmful, or you can't impact it like you can cholesterol. So let's say you have a high cholesterol, and your doc wants to put you on a medicine right away, and you say, wait, time out. Let's look for other causes. Don't you think maybe we should look for other causes? I eat pretty healthy. I'm not a big, heavy person. I'm not really uncontrolled diabetes. Why does a person with a body mass index of 25 have an LDL of 190? Should we look for other things? Of course. We should always look for other things. That includes sugar, because diabetics, the triglycerides will be higher. It includes thyroid, because low thyroid will lead to higher cholesterol. I've seen patients with cholesterols of 260, and they're hypothyroid. When you put them on thyroid replacement, the cholesterols go to normal. You should make sure there's not a liver problem. Liver makes cholesterol. There can be issues with the liver, and your cholesterol numbers can be out of range. And then again, kidneys. Kidneys are smart organs, and the kidneys release hormones, and the kidneys, if there's kidney issues that you can treat, you may be able to impact cholesterol. But by far and away, it's the thyroid and sugar. So what are secondary causes of dyslipidemia? We mentioned diabetes, thyroid, liver, renal tests. Check them. Now, I want to get to the evidence because people do not want to hear what I'm about to say, and that is medicine will save your life. It's overwhelming evidence that LDL cholesterol should be lowered. I already showed you this slide. You can lower your cholesterol from 190 to 160, great. If that's all you can do, you've just reduced your mortality by absolute reduction, nearly 1%, relative risk reduction, 33%. So no matter how well you're doing, great, go for it. Lower that cholesterol as low as you can. Overwhelming evidence that low is better. So it's unequivocal data, and we don't know how low is too low. Here's a meta-analysis, meaning we took multiple studies, put them combined as one, and reviewed the data retrospectively after the studies were done. And we found that for each 39 milligrams reduction in LDL, you had 29% reduction in major vascular events, which is significant. And those were people with LDLs already 77. So if your LDL is 77 and you lower it 39%, so 21 points, you just 29% less chance of dying, having a stroke, and having a heart attack. And that's starting at a very low LDL, which is very hard to obtain, 77. I told you earlier, I'm happy, I'm ecstatic. If every one of my patients was at 77, I would say this is wonderful. Get to 70, even below 50 is great. So now let's look at what are some of the therapies? Jennifer, how much time? I can split this into another talk because there's way too much to cover, but you let me know what you want.
5 more?
5 minutes? Okay, we'll split it into another talk. So I don't want to rush. This is too fun because I'm going to go into natural remedies as well. I'm not here to tell you everybody needs to be on a statin. I am here to tell you get that cholesterol low, and if you can do it with garlic and tea and eating healthy and all these other things I'm going to talk about, that's going to be part 2 because some people are going to want to come back and hear the natural remedies. But now, by far and away, if you're going to go home and do one thing, you're going to ask your doc, what is my cholesterol, what is my goal, and how can I get there? The evidence is overwhelming. When I was in medical school, we didn't even know what a statin was. This was 1983 to 1987. The 4S study, the major study showing the benefit to statins, came out in 1994. Before that, we didn't know what statins. We threw up our hands and said, you know, eat healthy, it is what it is. Now we have all these studies that show statin better, statin better, statin better, statin better. All the studies are showing statins are better than what? They're better than diet alone. They're better than placebo sugar pill. And some statins are better than others. So there's unwavering benefits to statins. Nothing should dissuade clinicians from using statins in high-risk patients, patients who already have heart disease, patients who are diabetic. Primary prevention, if you come into my office and you're 50 and want to know the benefits to a statin, that's different. Secondary prevention, unwavering benefits should be treated. And why is that? Now, let's look at justification for use of statins in primary prevention. That's a patient who comes in who doesn't have heart disease yet, but they want to prevent it. They're a lower risk than those of us who have heart disease or who have had a bypass surgery or a stent. These are primary patients, and look at this, 44% relative risk reduction, primary prevention, and relative risk reduction are all these events again. So if you have a family member that you're concerned about, let's say you have a child who's 20 years younger than you, doesn't have a problem yet, you're trying to prevent it. That's primary prevention. And the data is still overwhelming. P-value is 0.00001, which means highly, highly significant to treat them. Secondary prevention, that's most of us. I already have a problem, doc. What's the benefit? Every single study, starting that first 4S study that I mentioned, look at those levels of LDL. This was back in 1994. We were treating levels of 190 to 210. Now we're treating levels of 70, 80, 90, 100, and we're still seeing benefit. So people that tell me, doc, I just don't believe in statins, I'm not going to listen to that because the evidence is there. I will listen if they say, doc, I don't want to take it. And I'll say, why don't you want to take it? Because I know they can be harmful. Okay, in what way can they be harmful? Let's talk about it. I've had muscle aches, okay? I've had, and we're going to go through some of this because I do want to talk to the patients. I want to see what is your fear of taking a statin and can you do it without it? Let's look at diabetes, and then I think I'm going to call it just for questions, and then we'll complete next time. In diabetics should be monitored very carefully because your risk is nearly the same as a risk of already having a heart problem. So in most adults with diabetes, even if you don't have a heart problem, you should check your cholesterol yearly. Your LDL should be under 100. I didn't say 70, I said under 100. Triglycerides under 150. Very important. Usually the adult onset diabetes, those are the abdominal waist, bigger in the waist, the low HDL cholesterol, high triglycerides, and low LDL. And triglycerides in the diabetic are often high. So those patients you really want to talk to about alcohol intake, exercise, low carbohydrates, and check yearly. And again, the focus should be on lifestyle. I keep talking about medicine because it's so powerful, but it's always lifestyle. And you can see reduced saturated fat. We're going to get into fat in the next lecture on what is trans fat, what's monounsaturated, what's polysaturated fat, but reduce fat, increase omega-3 fatty acids, increase fish. You can fiber, plant steroids, weight loss, physical activity. All those things can help, particularly in diabetics. The ADA and the American Heart Association suggest different approaches. So they're going to say diet and exercise first, then medication if you can't get to goal. Statin therapy should always be added to lifestyle therapy regardless of baseline lipid levels if diabetic already has heart disease or if they're risk factors and over the age of 40. This is a very powerful slide. Hear that again. Statin therapy should be added to lifestyle therapy regardless of baseline lipid levels in a diabetic who already has heart disease. So even if your LDL is 70 and you say, Doc, that's low, that's normal, and I'm going to say, yeah, but you already had a heart attack. So what's to prevent another one? You need to be on a statin. So you have to look at the individual patient and say, what is your risk? What is your probability of another event? And then aggressively treat. So here's the fastest food in town menu. I'll have this, 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 and an order of statins. And I've always told Jennifer, I said, as long as I'm taking my Lipitor, I can have a 32-ounce ribeye this weekend. So just take the Lipitor and control it. So with that, I'm going to leave it. Now, there's so much to cover because I'm really excited about some of the natural remedies. And if you look on Mayo Clinic website, you'll see Mayo Clinic cholesterol therapy, and you'll see what they endorse as some of the natural things. So I want you to do your homework, and I want everybody to come back with one natural remedy or one plant-based or something that you can do besides a statin and see, okay, Doc, here's evidence-based medicine that says this therapy works. I don't want, because my great-grandma told me to take this, I want you to say, this has been significant proven benefit of drinking a liter of grapefruit juice or eating this much cinnamon or taking this much krill oil. See what you can come up with, and we'll just do a little, I'm not going to put anybody on the spot, but if you have some interest in comment, I want to hear about it. And then we're going to look at evidence-based medicine, see what's of proven benefit. Because again, if you can do this without me prescribing a medicine, I'd rather do that. However, I'm going to be very insistent on a high-risk patient who already has disease or a diabetic patient who's 40 with disease. I am going to aggressively recommend lipid lowering with statin therapy. Good news is, for all of us who can't take statins, and the literature says 2%, in my practice it's probably 10%. There are 2 new drugs on the market which are life-saving. They're monoclonal antibodies, essentially no side effects or very rare. And you can, with one dose, you can drop your cholesterol 200 to 300 points. We're going to talk about that further. And those are the new class of drugs called PCSK9 inhibitors. So there's hope for you sitting here that says, Doc, I can't take statins. I've tried 3 or 4, and my muscles or my whatever it is. We'll discuss side effects, real and myths. And there is hope. There are other new drugs which are out there that are wonderful. So now I'm going to, next time we meet, I will finish the discussion, go over some of these natural remedies and other therapies, and then maybe even show you some pictures of some neat coronary events that happened that we were able to intervene on. So I'm going to open it up to just a few minutes of questions. Is that all right? Okay, any questions today on what was presented or anything in general with cholesterol?
One of your comments were on muscles from the statin drugs. What's your thought on the CQ10?
Oh, I have 2 slides on it. Yes. My thought is, yes, I think about it.
Can you repeat the question for the video?
Yes. The gentleman said if somebody has muscle aches from a statin, what is your feeling on CoQ10? And my feeling is try it. It's harmless, it won't hurt you. There's some evidence that statins can cause damage to muscle tissue by oxidation, and you'll deplete CoQ10 levels, and you may be more prone to muscle aches. There's no data that says to prophylactically put it on, so if I prescribe a statin, I don't prescribe CoQ10 at the same time. But there is data, and we'll go over that, that says try that first. So we're going to try 5 different scenarios of if you're having trouble with statins, what I would recommend instead of just giving up on them. But CoQ10 would be one of the first things you're going to do, which is over the counter. You see it advertised on TV. The #1 doctor recommended Quinol, and it's like, I don't recommend brands. There's no brand that's better than the rest. It's a marketing gimmick. But yes, I would definitely recommend that.
Thank you.
Any other questions? Yes.
Are these new things affordable?
No. On the question, are the new cholesterol-lowering drugs affordable? No. The PCSK9s cost $14,000 a year. The insurance has denied it now for 2 years. They said, no, we're not going to pay for that. Are you nuts? It can't do that anymore because we just have the new data which was published showing it saves lives over statin therapy. If you can't get to goal and you add this drug, I just saved for 50 patients I treat, I'm going to save another life. And for people who can't take statins. So before it was just a number, we didn't have the good data. Now we have, if you're on a PCSK9, you have less chance of death, stroke, heart attack. So the insurances are not going to be able to deny this. The problem is they'll approve it and then stick you with a copay of $600 a month. So, you know, if you have a copay of $600 a month, I don't know how many can reach into their pocket and give the drugstore $7,000 for one drug when you're on 6 different drugs. The upside, though, is there's becoming overwhelming data that these drugs work. So there's more competition. There's now 2 on the market. I speak for another company. I just started speaking for them. They have one that's going to come out in a couple years that's oral. There's assistance programs. So it takes my nurse on average 2 to 3 months to get one of these drugs in your pocket so you can use them, and so it's affordable. So we have to go through specialty pharmacies. We have to look at your income, your disposable income. We have to apply for grants from the companies. We'll get them in the hands of those who really need it and make it somewhat affordable, or try to get samples. But, I mean, if you have homozygous familial hyperlipidemia, cholesterol of 600 and you're 20, you're going to be dead in your 30s unless you're treated. If you have familial heterozygous hyperlipidemia and LDL of 190, you are going to have serious problems unless you get that LDL down. And now we have a drug that can do it. So you're going to see a huge paradigm shift switching from completely statins alone to maybe lower level that your muscles can tolerate, and then maybe adding the new ones when the price is more reasonable. Great question. Price matters. Because half the people don't tell me, why are you not taking the statin? And they're like, I can't afford it. So I take it 3 days a week instead of every day. Or they're embarrassed and they don't tell me. And you know, price is a real thing. Statins now are wonderful. You can go to Myers and get a Torvastatin for free. They give it away so you buy your other prescriptions. So statins are dirt cheap now. So that's no longer an excuse as far as being able to afford it. It usually comes down to the side effects of the medicine. Yes?
My wife's on Prevalent, I think you pronounced it.
Yes.
Is that one of those?
Yeah, that's a PCSK9. That's Praluent and Repatha. Unbelievable. I stand by them. Just for disclosure, I do speak for both those pharmacies.
Way down when she got on.
You better believe it's going to come down. There's only 1% of people who are not going to respond to them. I've had people who I could not get their cholesterol below 300. Heart attacks in their 50s, couldn't, stents like you wouldn't believe, 2 open heart surgeries on maximum statins. I put them on Praluent, and a month later their cholesterol's 150. I had people crying in the office, they were so happy. So yeah, the drugs are out there. And did you get assistance? Was yours?
Express Scripts.
Express. So every insurance is different. Some people it's no problem. Others look at me and laugh and say, "You have got to be kidding, doc. You know, there's just no way." Next question. Yes.
What's the function of L-arginine? I mean, it's an over-the-counter. What does that do for coronary stuff? For coronaries, there's no evidence that it really is beneficial at all. I'm going to look that up. I don't know specifically on that. There's nothing in the literature that I know of showing a benefit to doing. You know, that's used in enzyme production, many things. It's probably not harmful, L-arginine, but I don't know. Let me do a little homework and come back to you on that, because I'm not aware of one study
with that showing benefit. Could you write that? No, I'll remember, it's fine. I'll have some data next time. Any other questions?
Do you have any handouts?
Yes. Do we have anything today, Jennifer?
Yeah. Just looking, and there'll be more handouts next week, or next month.
And in the office, there's quite a few handouts on diet, because I'm a big proponent of the Mediterranean diet. For whatever reason, the medical societies have been slow to change their thinking. They refuse to acknowledge their errors. And we make errors in medicine. But it's hard to change that. And the American Heart Association, American College, and the Dietetic Association, it can be years and years. It's like moving a dinosaur before they finally adopt new things. And we've been preaching forever that low fat is the best diet. And low fat is important, but we probably know more now. So yes, low fat, don't go home and say Dr. Felton said it's not important and I can just eat all the fat. It depends on what type of fat. Trans fat is horrible. All the pre-processed things, all the things you get at the store that are not natural, they're loaded with garbage fat. Trans fat is evil, avoid it, but the Mediterranean diet, if you're looking head-to-head, beat the low-fat diet, head-to-head randomized diet published in the most prestigious journal, the New England Journal. And I think we as a society have been slow to really teach patients that. So when you come and see me, and there's dietary concerns, I hand you the publication made more for the average non-medical person, and then a little sample of that diet. But the computer is so powerful, I tell people just Google Mediterranean and you'll see the benefit, which is basically fish, vegetables, nuts, legumes, oils instead of animal products. It's a very, very healthy diet. I strongly encourage it. Yes, well, do two more questions.
This is a different topic, but related. I had bypass surgery about 4 years ago. Prior to that, I had accumulated 21 stents, and I was accumulating them near the end there, about 1 every 6 months. Since then, I've not had a single stent. Why don't I continue to have to have stents after the bypass?
You have not had stents after the bypass?
Not a single.
Okay, so this is a question. Doc, before bypass, I had problems. I had stent after stent after stent, 21 stents. Now I've had surgery. It's been 4 years. I haven't had another stent. Why is that? Did I cure disease? Heck no, we didn't cure anything. We just bypassed around the blockage. Stents do not cure heart disease. That's what I do for a living. I can save a life. I can make your quality of life better and reduce angina, but I didn't change the natural history of heart disease. Coronary bypass saves lives. It can prevent death. It can prevent better quality of life. You can get rid of angina. And guess what? Coronary bypass usually lasts 10 years, the average vein graft. And people after surgery will generally do great for 10 years and not have any angina. During that time, though, and I'm not saying I have patients who have a bypass who are 30 years later and never had an issue. Because you were one who was building up, your body was full of inflammation on the stents and it was saying, I do not like a stent. And your stents were re-narrowing. That's not supposed to happen. 20 years ago, our first stents, 20% of them would re-narrow. The current stents, when I put in now, I tell a patient you have a 9% lifetime chance of re-narrowing in this stent if you take care of yourself. But once they re-narrow, if you have that body, that inflammation or whatever is causing that stent to be quote-unquote rejected, you can keep putting stents and the process can still develop. Surgery, though, is different. They take a conduit and bypass around the narrowing, hence the word bypass. So you have a complete new circulation. It's not dependent on those stent arteries anymore. The problem is you still have to control risk factors because the bypasses are veins. There's an artery which we use that can last 30, 40, 50 years.
So that cholesterol started growing a long time ago.
Oh, when you do autopsy series in Marines who are healthy as can be in their 20s and look and cut their coronaries, they already are developing hardening of the arteries. So it's a silent killer. So we don't know, you can go on, this guy, this gentleman yesterday, apparently nothing. Sees his doctor regularly, didn't know he had a problem. His wife is just, I'm sitting across the table and her husband just died with no warning signs. Coronary disease, this stuff we're talking about is a silent killer. Sometimes you just never know. That's why I said if you're lucky and you have a 70% blockage which starts causing angina and we can catch it in time, that's what you want to do. So stents, the number of stents, you can put in many, many stents, but once you start getting in stent narrowing, it's a point of diminishing returns and often will lead to bypass surgery, which is longer lasting, thank goodness, than our older stents. Current stents are pretty much as good as bypass in certain cases. One more question. No other questions? Wonderful. Oh, one more question here. I love taking questions.
I'm on, I think, one of them new cholesterol medicines.
Okay, do you inject yourself?
Twice or every other week.
Okay, so you are.
Okay. Dr. Gilman put me on it.
Okay,
And I did get assistance.
okay,
And I cannot take statins.
All right.
I'll just cripple up and fall. And he was after me like you would be. Statin. I said, Doc, it's right in my records. I cannot do this. He said, I'd like to try this on you. Would you? I said, okay, I'll work with you. 3 months, I come from 150 down to about 80.
yeah. So here we have a gentleman, Bill. I'm talking for the audience who couldn't take statins, myalgias, problems. The doc kept hammering him just like I do. Although I will listen and say, boy, you're right. This is a problem if you fail 2 or 3 statins.
He listened.
He listened, and I know this cardiologist, he's excellent. Put him on a PCSK9, one of those new ones that I said are $14,000 a year. In this room alone, I love to hear this because this is a small audience. We have 2 success stories. 2 success stories with PCSK9s, and both patients are able to afford them or have insurances which pay, and both have been successful dropping the LDL tremendously. So don't give up hope. So don't give up hope. If you're one of those that, Doc, I really have tried. I've done everything you said. I take CoQ10, you check my thyroid. I can't take a statin. And you're serious about it, and we'll talk about it, because there's true intolerance and then there's no. An elbow ache after bumping it is not a statin side effect. So this is great. We may actually have more than 2 in the audience, possibly 3 for sure. So in a very select group, small, we have success stories. I'd love to hear it. Thank you.
Actually, I'm getting mine free.
Yeah, and I'm telling you, the companies are serious. It's almost unethical not to get these drugs in people's hands when we know they work. And if it comes down to a money thing, we have, as society, have an issue. But we will do our best. Midland Physicians Group cardiologists will do their best to get you the drugs. And fortunately, I'm on both companies' speakers list, and we can sometimes help pull a few strings, not always. I'll give you a story and then I'll shut up. I had one of the salespeople, his uncle had horrible disease his whole life, high cholesterol, and he came in with a massive heart attack. I did what I did, put a stent. He walked out of the hospital a day later, put him on a PCSK9 drug. His cholesterol dropped from nearly 300 to 130, was doing fine, and then his company stopped, didn't pay for it and cut him off. And this was the uncle of a pharmaceutical rep who got, so it's a game. It's a game we play all the time, which unfortunately is part of medicine. But this country, we're so blessed because we have so much technology and such good drugs to use. And you don't have to sit there at home and worry about, I just can't do this. There are other options. With that, we're going to end the talk. Next time is even more exciting. Now we went through sort of the boring data, but now we're going to go, what can I really do? And what about statin side effects? I'm going to look up L-arginine, and we're going to have one more talk about lipids. And then I want you to let Jennifer know what other exciting talks. I don't want to talk about sex after heart attacks, so I told Jen, that's out of my comfort zone. Get somebody else. So thank you.